Hi, this is Dr.Reuben here, and this is going to be a short talk on what I routinely do when it comes to isolating class 2 endodontic cavities. Again, I repeat routinely, not every single time, because every clinical scenario will have its own demands and requirements. To begin with, I want you to take a good look at this picture. I'm sure the first things that come to your mind are the well-designed endodontic access cavity and the good isolation technique. But then there's something that you're entirely missing here. So if you zoom in, you will see that I have left behind a lot of caries proximally, despite the fact that the whole endodontic procedure has been completed. The only thing that has to be done at this point is obturation. What we all have been taught conventionally as endodontic students is to completely remove the caries before or the first thing before you initiate your endodontic procedure. The question is, does this hold good in every clinical scenario? The answer is no. Let me explain why. So every time I do a root canal, the first thing I do is take a good look at the radiograph and understand the restorability and prognosis of the tooth. Once I'm convinced with the outcomes, then I move into the endodontic phase. During the endodontic phase, I remove caries only enough to go ahead and initiate my access cavity preparation, clean shape the canal, disinfect it and obturate it. Then I move into the restorative phase where the caries removal is far more complete, and then I plan my post-endodontic restoration. Let me explain why this might be a good order of things to follow. Take a good look at this picture. What you can see here is there is a good access cavity preparation. The isolation is complete, but then there is this little bit of caries that is left behind on the gingival seat. Say for example, if I tried removing that caries completely at this point, the things that can happen are the rubber dam is going to warp right into the access cavity, blood and saliva from the gingiva is going to get in as well and compromise my isolation. This is something I do not want to handle at this point. I'd like to compartmentalize my procedure into different sections and focus only on the one at hand and not handle two different scenarios at the same time. So here's another variation of what we have discussed earlier. So this is a tooth which has a fracture proximally. So generally these fractures run deep, and if you drill into these fractures, there's a very high possibility it is going to go well below the gingival margin and you're going to get stuck for isolation again. So what I do again when I anticipate a deep cavity is I stick a wedge in between the teeth proximally. So what the wedge does here is it holds the rubber dam down along with the gingiva well below the level of the defect. Here it is a crack, but then the same thing applies when you have deep caries in the proximal area as well. Having discussed a few shortcuts on how to isolate these class 2 endodontic cavities quite predictably, I must also tell you the best way to go about it is to learn how to do it the correct way first before you try out these techniques. So I'm going to show you a couple of cases where it has been done the conventional way. So this is just the typical deep proximal cavity. We can definitely expect the margin of the cavity to go well below the gingiva here. So here in this case, I've used a cautery machine to do some amount of gingivectomy to elevate the deep margin of the tooth above the gingival level. And that's the tooth isolated. Whenever it comes to multiple teeth isolation, I always prefer a latex-free heavy rubber dam. This is just a magnified image of the previous picture to show you the control I have over the workspace once the rubber dam has been placed and inverted well below the margin of the tooth. This is another case of a lower molar where I have a deep margin on the distal surface. So everything that was discussed in the previous case has been done here. Gingivectomy, a rubber dam placed, and in addition to that, I've also passed a wedge in between here. The caries removal has been complete, and what additionally I have done here in this case is I have built up the proximal wall, a pre-endo build-up which wasn't done in the previous case where I banked entirely on the rubber dam inversion below the margin of the tooth. And that's the same case obturated with the post-endodontic restoration. With this, we come to the end of this little talk. What we have discussed here is something that can be added on to your existing isolation technique, and I really hope you found it useful. And in case you have any doubts or clarifications, please feel free to get in touch. Thank you.